All right, hello everyone. Welcome to part 2 of chronic pelvic pain. If you've made it this far, you've probably watched Kelly's awesome presentation on the first half. So if you haven't watched that, go and watch hers and then come back here. So let's begin, shall we? Here's the learning objectives so that you can put the strongly agree on my stated the learning objectives feedback from the post-lecture survey. My goal at the end of this is really to give you guys a good picture of the differential diagnosis for chronic pelvic pain. We'll kind of go over things 50,000 foot view and then 30, and then we'll kind of hone in on some specific diagnoses and talk just briefly about some of those. And of note, number 4 learning objective will be talked about more on Friday with some special guests. So I think that the systems-based approach to the differential is the most helpful and useful and easy, the easiest one to learn from. So that's the approach that we're going to go. So these categories will come up more frequently in the slides to come. So first of all, for the gynecologic causes, obviously that's going to be a major consideration in a young woman or old woman with pelvic pain. So the ones that we'll talk about are the ones in bold here. So endometriosis, leiomyoma, adenomyosis, ovarian remnant syndrome, pelvic inflammatory disease, and vulvar pain syndrome. So these are kind of the ones that are either most common or have some special clinical relevancy to talk about. For the urologic causes, we'll look more into interstitial cystitis, painful bladder syndrome, is another name for it, radiation cystitis, bladder cancer. And again, all of these are perfectly reasonable things to have on your differential, but we're just going to kind of hone in on the ones in bold. For GI causes, irritable bowel syndrome, inflammatory bowel disease, constipation or other motility disorders, colorectal carcinoma, obviously not as common, but something that we don't want to miss, and then diverticulitis and diverticulosis. Myofascial pain syndrome, very common cause of chronic pelvic pain. Fibromyalgia, another thing that we want to consider. For the neurologic causes, we can have this abdominal wall, cutaneous nerve entrapment or injury to one of those cutaneous nerves, and then kind of a broad category of abnormal neural messaging that we'll talk about here in just a little bit. Vascular, this comic has to do with clotting. This doesn't really have to do with clotting, but it's a blood-related comic, and I thought it was amusing. So vascular causes could be vulvar varicosities or pelvic congestion syndrome. That one a little bit controversial. We'll talk about that. All right, so here's a summary of all of those bold-faced ones that we will now go into in a little bit more detail. But first, it's not really useful for me to go through and tell you all the questions you need to ask in order to take a gynecologic history. So I'll save your time and mine with that. I thought it would be more efficient to go through and talk about some of the kind of the buzzwords, some of the common presentations of some of these common or clinically relevant diagnoses. So for gynecologic causes, mentioned endometriosis, obviously very common cause of pain. We've talked about it before. We kind of get the cyclic pelvic pain picture that starts 1 to 2 days before menses and then persists through. Contrast that with primary dysmenorrhea, which will start usually on the first day of menses or the first couple of days of menses rather than a couple of days before. So that's an important historical tidbit. Remember the 3 Ds: dysmenorrhea, dyspareunia, and dyschezia. You can also have infertility, and you may be able to palpate a pelvic mass. And these do account for a considerable number of the diagnoses when you do decide to go in for a laparoscopy, a diagnostic laparoscopy. For leiomyomas, the esteemed Dr. Anderson talked about this last week, I believe. 2 weeks ago, excuse me. Very common, but it rarely causes pain. So, when we see it on the ultrasound, when we see it on the CT scan in a woman who has pelvic pain, don't jump to that conclusion. Consider other causes as well. So, careful with that one. Adenomyosis, essentially endometriosis, but with these stromal tissues located in the myometrium of the uterus. Classically, women in their 40s or 50s, endometriosis can often present much younger than classic adenomyosis. And this is a good place to talk about Mittelschmerz. It's a nice wards style question that you may be pimped on. So this is a surprisingly common phenomenon that many women experience. It's Mittelschmerz is literally middle pain in German for all of you Germans out there. And it's this pain that kind of comes on suddenly and then subsides over usually a few hours, but it can persist up to days. And it's related to ovulation, and some women even feel the pain so locally they can tell which side they ovulated on. Very interesting. There's a few other gynecologic causes. Ovarian remnant syndrome, probably more common on the boards than in clinic, per Dr. Hedges. But think of a woman who had a bilateral oophorectomy and then present with these symptoms related to accidentally leaving some of the ovary behind. And we do want to contrast this with residual ovary syndrome, which is where we left some of the ovary in on purpose. So this was kind of an accident that we left it in there. So you'll get kind of the cyclic pelvic pain. You may be able to feel a mass, may have some ureteral obstruction. All right. Pelvic inflammatory disease. So if you have pelvic inflammatory disease, you're about 30%. You have a 30% chance of developing chronic pelvic pain from that. Your likelihood of that increases if you fulfill the 2 following factors. 1, your pelvic area kind of got blasted and has sustained a damage. Or 2, you kind of have this persistent pelvic pain even after appropriate treatment after about a month of that. That can increase your likelihood. All right. And then vulvar pain syndrome. So kind of the theory behind this is that you get some kind of trauma to the vulvar area, you get this inflammatory response, and then in certain susceptible individuals, this can kind of proliferate the nerve fibers in there and lower pain thresholds. It kind of results in a central sensitization of the pain. Moving along to urologic causes. So this interstitial cystitis, painful bladder syndrome, quite common. Often goes with IBS, fibromyalgia type picture. Labs are really normal in these patients. You may get a history of certain foods or beverages making the pain worse. The classic symptoms are that you have this chronic pelvic pain that's worse when your bladder's filling up and then gets better after you pee. And you may also have some urgency and some frequency, but not generally incontinence. So that kind of points away from that picture. For radiation cystitis, consider this in women who have had radiation therapy to the pelvic area. And then bladder cancer can kind of look like interstitial cystitis, but often will have gross hematuria also, which interstitial cystitis likely not have. And so you want to consider your risk factors in screening women for this, or men for that answer. All right. Moving along to GI causes. So IBS, you kind of get this chronic intermittent pain that is associated with the bowel function. So this goes back to taking our history, making sure that we hit all of those different systems that I mentioned at the beginning. So take a good urologic history, take a good gynecologic history, take a good GI history, and this can kind of point you in this direction. I saw one study that showed this was the most common diagnosis for patients who present to their primary care physician with chronic pelvic pain. Along the same lines, consider the inflammatory bowel disease. And then chronic constipation, very common in women, but not necessarily a common cause of chronic pelvic pain. Colorectal carcinoma, kind of same thing with the bladder cancer. You want to consider the risk factors for these patients. Take a good bowel history, good family history, etc. And then diverticulitis, diverticulosis, remember that's classically the lower left quadrant pain in an older individual, 60 to 70 years old. This myofascial pain syndrome, like I said earlier, very common. And essentially what we have is there's some kind of pain generator, whether that's it got hit with an inflammatory disorder that you have, you ovulate, or you have the cyst rupture, childbirth, surgery, trauma, urinary tract infection, yeast infection, etc., or endometriosis, interstitial cystitis. So all of these can kind of contribute to this micro trauma, quote unquote, except for maybe the childbirth. I wouldn't consider that a micro trauma, that can lead to this kind of these tense, spasming abdominal or pelvic muscles. You may see the Carnet sign, and we'll get a demonstration of this by Dr. Hedges on Friday. But essentially what it is the physician will kind of push on an area, and the patient will then, the area that there is the most tenderness, then the patient will kind of tense up. If that pain gets worse, then it will point more toward a myofascial pain syndrome like picture. If the pain is lessened, then consider more visceral causes. All right. And then also that one of our special guests on Friday is a physical therapist who specializes in treating a lot of these pelvic disorders, and so we'll certainly get to hear from her on the treatment of this syndrome. Fibromyalgia, kind of one of those tough diagnoses to pinpoint, but consider it in these patients with chronic fatigue, depression, IBS, somatization, etc. The American College of Rheumatology puts forth these criteria for diagnosis, that you have pain in all 4 quadrants of the body, and the physician will detect pain on at least up to 11 of these 18 spots that they've set out. Neurologic, so we can get this abdominal wall cutaneous nerve entrapment. Essentially you have some kind of trauma or injury or strain to abdominal muscles, nerves, kind of the classic incision for a C-section can cause this. And what is that called? That's right, a Van Steinel incision. Very bad, very bad. fan and steel scission. I've misspoken. A fan and steel. Couldn't find my notes there for a second. Or also a fan and steel. For all of you psychics who prefer to play with pet ptarmigans and pterodactyls. It's often frequently confused for visceral pain, so often these patients will have extensive workups looking for the cause of the visceral pain, but they need not look further than the surface. And then this picture of abnormal neural messaging is it's a messy one, and often is a diagnosis of exclusion after we've looked at some of these other factors. You really do want to take a good history and of the physical and sexual abuse. So up to 47% of women with chronic pelvic pain disclose a history of physical or sexual abuse. And that's very high. Almost half of women with chronic pelvic pain will have some of this physical or sexual abuse in their history. So it's good to tease that out. It can really mess with the HPA axis. These women have an increase in their adrenocorticotropic hormone levels, which can lead to kind of this more sensitization of pain. And so we certainly want to screen for that and screen for depression, as depression is has a higher incidence, higher prevalence in women with chronic pelvic pain. So vascular causes. One would be vulvar varicosities. So a woman gets pregnant, she has these varicosities in the vulvar area, and oftentimes they don't resolve after pregnancy and can be really painful and itchy, and can be worse with standing. So certainly look for those on physical exam if that is the complaint. And then pelvic congestion syndrome is pretty controversial. But say you have a woman with deep dyspareunia, maybe postcoital pain, worsening pain after long periods of standing, and so you get some radiographs and you see some dilation of some of the veins, the uterine vein or the ovarian veins, and some reduced blood flow. It's kind of like the fibroids in that it's a really common finding in women who are asymptomatic, and so don't jump on that diagnosis right away. So that is the overview of some of these causes of chronic pelvic pain. I hope you have a better picture of the differential diagnosis at this point. On Friday, our special guests are going to be Chris and Karen. Chris is a physical therapist here in Colorado Springs who specializes in the treatment of chronic pelvic pain and these other pelvic problems. Dr. Hedges says that she loves to send people over to her to get healed. Karen is a patient advocate who has a story with chronic pelvic pain and has this website that has a lot of resources for patients with chronic pelvic pain. Very cool. You should check it out, and she will come and join us on Friday. And then we have the esteemed Dr. Hedges will be there on Friday to give us some physical exam pearls and then talk about some treatment modalities as well. And then your very own Kelly and Ben, we have some cases prepared to go over as a group as well. So thanks for watching, and we will see you on Friday. Bye-bye.